Good morning, respected chairpersons, my seniors, teachers, and dear colleagues. So radical cystectomy or bladder preservation, who would you bet on? This is not a new question. It's been more than 2 decades when the first report on TMT was published, and we're still finding the answers. Whenever we think of MIBC, we think of radical cystectomy. Why are we not confident in offering trimodal therapy to our patients? Maybe the literature is not supporting us or not giving us more confidence to treat our patients. We don't have an RCT. Whichever RCTs were published were called off because of the insufficient accrual. So what is the answer? Radical cystectomy or trimodal therapy? To answer this, 3 high volume centers did this study, 2 from US, 1 from Canada. This is a retrospective analysis of 722 localized T2 patients with no nodes, non-metastatic. And they observed them for almost 12 years with a good median follow-up close to 5 years. All patients had solitary tumors less than 7 centimeters, no or unilateral hydronephrosis, no CIS or at least extensive CIS. These patients were ideal both for radical cystectomy as well as trimodal therapy. The primary endpoint was metastasis-free survival, and the secondary endpoints were other survival parameters. The differences in the outcomes were matched with propensity score matching. After matching, the variables were similar. They did a very good extensive analysis, and the propensity score were incorporated in 2 ways, 3:1 matching and inverse probability treatment weighting. The groups were balanced between the important prognostic factors. In results, authors found that there was no difference in both the arms, whether it related to metastasis-free survival, cancer-free survival, or disease-free survival. There was a marginal benefit in terms of overall survival. Salvage cystectomy was required in 13% of cases, and this figure is almost equal for all the other researches, close to 90 to maximum 20%. And this is due to invasive recurrences, muscle invasive as well as non-muscle invasive. The bladder recurrences, in bladder recurrences, were in the tune of 31%, 20% being non-muscle invasive and 11% being muscle invasive. Pelvic recurrences was observed in 8% of cases compared to radical cystectomy, it was 3%. No patient died in 90 days after trimodal therapy, which was around 2.5% peri-op mortality rate in radical cystectomy. And the muscle invasive recurrences occurred within 2 to 3 years, and non-muscle invasive recurrences were present even after 5 years, stressing the importance of long-term stringent follow-up. What are the strengths of this study? It represents a large multi-institutional cohort of patients with a very detailed database. They include important clinically relevant endpoints, not only overall survival. This constitutes the consistent results among all these 3 centers speaks the generalizability of these results, at least in the across the high volume centers. Good quality statistical analysis done by 2 expert statisticians separately, and the high quality of surgical outcomes as shown by the high lymph node yield, very low positive margin rate, low local recurrences rate, and high cancer specific survival. There are a few limitations. Being retrospective, there is potential for residual confounder selection biases. These results represent a well-selected muscle invasive, so it cannot be applied for all muscle invasive bladder cancers. I could find no discussion on the toxicity, side effect, or quality of life metrics which we are interested in clinical practice, nor were the discussion on the cost. At the end, authors concluded by saying, in the absence of randomized trial now or in the future, this study provides the best evidence possible supporting that trimodal therapy should be offered after a detailed multidisciplinary meeting, at least in high volume centers, to all eligible candidates as an oncological equivalent alternative to radical cystectomy. Most important thing here is the eligible candidates. Who are these eligible candidates? Ideal candidates being T2, no hydronephrosis, no CIS, unifocal mass, eligible for cisplatin, visibly complete TURBT, good bladder function, and the capacity. Less than ideal, which we can offer, T3, incomplete TURBT, multifocal masses, poor bladder function or capacity. Not very ideal, but yes, there are no contraindications. Contraindications relative being T3B, T4A except stromal invasion, which is an absolute contraindication. Diffuse CIS, lymph node positive, regular follow-up is question mark. And in which we cannot offer trimodal therapy are T4B, hydronephrosis, tumor related, prior pelvic radiation therapy for other cancers, chemo-ineligible patients, and prosthetic stromal invasion. So to take home points, we still lack the level 1 evidence. We don't have RCT now, or at least in near future. After all these researches, TMT appears to be an oncological equivalent alternative to radical cystectomy, at least in high volume experience centers. So again, going back to our question, what is the answer, TMT or radical cystectomy? The most important question is not which, the most important question to be asked is when. Which patients are eligible for radical cystectomy, which are for trimodal therapy. So patient selection is the key. Most important second point is patient counseling. They have to be informed about the need for salvage cystectomy, almost in the tune of 15% of patients. The limitations in the divergence, orthotopic neobladder are practically difficult in cases. The morbidity is very high in radical cystectomy patient after chemo radiation. And the requirement of stringent follow-up because non-muscle invasive recurrences were still present after 5 years. If patient is eligible for this, yes, then the answer is trimodal therapy. But we still need further studies on tolerability of trimodal therapy. Thank you so much.